Good afternoon. So let us begin today's topic, which is violent and homicidal patient in psychiatric emergency. So this is something which you are very much frequently aware of. You'll see these patients in your day-to-day life, not just in emergency. You might see in your private practice if you're going to do it in future. We'll be covering it under the following headings. So what do you mean by violence? Violence is defined as the intentional use of physical force or any other power which is threatened or it's applied actually. It could be against your own self or another person or against a group or community that either result in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment or deprivation. It's not that violence will always cause a harm, but it has very likelihood of causing a harm. Violent behavior, again it refers to any action where physical force is used to harm or threaten another person. It can range from minor assault, thappad maar diya, to aggressive physical form or including murder or severe physical harm. Then we have homicidal behavior. What do you mean by homicidal behavior? Any thoughts, action or the intent to kill another person. It can include both premeditated or impulsive action that can result in another person's death. Homicidal ideation is something wherein you have the thoughts regarding harming someone, which can range from vague ideas of revenge to detailed and fully formulated plan without the act itself. So they are just ideation. Action part will be lacking, but the ideas will be present. So types of violent behavior, what all patients you can see verbally aggressive patient. It includes language to harm or intimidate another person. It may involve shouting, threatening, insulting or using abusive language, which is aimed at provoking fear or distress among the individual. Physical aggression, use of physical power to cause harm the another person, for example, hitting, slapping, kicking, punching, biting or throwing objects at someone. Next is property destruction. This is also something you are quite familiar with. Violent behavior involves intentionally damaging or destroying personal or public property as a form of aggression, which is often associated with emotional dysregulation or frustration. You might break the windows, smashing furniture or vandalizing the property. Again, the violent behavior could be divided into impulsive violence or premeditated violence. What is impulsive violence? Impulse itself means action without thoughts. So the thought part will be lacking here. Acts of aggression that occur spontaneously, often as a reaction to a stressful or a provoking situation. It is characterized by lack of planning and emotional dysregulation. For example, you are having a conversation and heated argument can turn into verbally abusive or a physically abusive act without even thinking you might get physically abusive. Premeditated is something where you have a clear plan of assaulting or carrying out a homicide towards someone else. So in emergency department, globally the studies say, depending upon what kind of facility you are in, 10 to 50% patient can present, psychiatric patient can present with violent behavior at some point of time in their care. Similarly, in India as well, there are certain studies conducted which says about 15 to 25% of psychiatric patient in emergency setting can exhibit violent behavior. Verbal aggression followed by physical aggression is common. What are the etiology and risk factor? Again, biopsychosocial model of disease is quite important here as well. So the interplay between biological vulnerability, psychological and environmental stress, medical condition is important in understanding the etiology. So genetic predisposition, there is a gene called MAOA gene. There is a mutation of polymorphism in that. This gene is also known as warrior gene, which is linked to increased aggression and impulsivity. Again, younger age group, especially 18 to 35 age group, male gender is more prone for having violent and aggressive behavior in comparison to female. But it doesn't rule out that female won't be violent or aggressive. Again, neurotransmitter dysregulation, dopamine and serotonin level dysfunction can lead to violent and aggressive behavior. Medical and organic causes should also be taken into consideration. Patient with traumatic brain injury, electrolyte imbalance, post seizure confusion, and in delirium patient can be violent and aggressive. Brain structural and function abnormality like amygdala hyperactivity, or if there is frontal lobe dysfunction. So there, these situation can also lead to aggressive behavior in the patient. Higher level of testosterone have been linked to increased aggression in both in men and women. Psychologically, mental health disorder, as I've already discussed with you, personality disorder, especially antisocial personality disorder, borderline emotionally unstable personality disorder per se has high likelihood of having aggressive and violent behavior. Again, in substance intoxication, alcohol intoxication, and stimulant like methylphenidate, etc., are associated with aggressive behavior. There's a term called impulse control disorder. So it is a disorder which is characterized by sudden, uncontrollable outburst of aggression. That is, this, remember this term, disproportionate to the triggering event. So the event might be very small, but the reaction of the person would be way out in comparison to the impulse or the event which is there. So these patients are also more prone for violent outbursts and property destruction. Environmental and social factors, childhood abuse, how many a time patients or the children who have been, physically or sexually or verbally abused in their home, they normalize the violent behavior. For them, it is a normal way of responding. Experiencing physical, sexual, emotional abuse during childhood is a significant risk factor for the violent behavior in adulthood. Children exposed to violence may normalize aggressive response to conflict. Individuals living in poverty or facing chronic unemployment experience heightened stress, frustration, and social marginalization, which increases the risk of violent behavior. Again, socially isolated people are said to have more violent tendencies. And easy access to firearms is one of the cause which is seen not in India but in European or Western countries. You can see that easy accessibility to firearm increases the likelihood of homicidal tendencies. Especially in United States, you might have seen there are several school में जहाँ पे बच्चे firearm लेके चले जाते हैं, and there have been many incidences where which has resulted in several amount of casualty. So this is just to say that how is the patient going to present to you and how are you going to assess. So this is something in emergency you should be able to recognize. Behavioral sign पहले तो देख के patient को, he might feel agitated and restless, he might pace around, there might be fidgeting, he might be clenching his fist, walking around, might start with verbal aggression, he might get aroused by even a minute of the stimulant. कोई थोड़ी सी तेज आवाज हुई उससे भी उसको गुस्सा आ गया, किसी ने उसको पानी के लिए नहीं पूछा उससे भी गुस्सा आ गया. So threatening speech, abusive language or loud outbursts. Then it will start to physical aggression, unprovoked act of violence. Like it might not directly start with being physically abusive towards the healthcare worker, but he might start punching himself, he might start throwing object, then going towards physically attacking healthcare staff or nearby. Patient might engage in self-directed violence such as cutting himself, head banging, punching the wall, etc. Then psychological symptom, this is something we can rule out in history part as well. Key patient might have some delusion, hallucination, impaired judgment, some anxiety or fear associated. So autonomic signs of hyperactivity can also be noted in these patients like sweating, tachycardia, pupils are dilated, breathing is rapid and shallow, muscle tension, ready to fight posture are common, indicating that patient is physically preparing for a violent act. Signs of intoxication or withdrawal should also be taken into consideration. Okay, history part and examination part is quite tricky in aggressive patient because you might not get that much of time, but still keep in mind that you might know that there is any substance abuse ka history or not, any past history of any violent attack or any especially recent episode where in public or at home he has got aggressive. Legal history, prior history of arrest or any restraining order is there, and rule out psychiatric condition as well. Any acute stressor, and how is the family dynamic at home. Physical examination, as I told you, is quite tricky. It should be very quick, focused, and strategic, aiming to gather essential clinical information, like just checking of the vital signs of the patient. Brief neurological examination to rule out any traumatic brain injury, any intoxication or delirium status is there. Physical signs of substance abuse, and always look for injuries. If patient has sustained any injuries or self-harm itself. MSc में most of the thing you can make out from the behavior what the patient is saying, whether he's agitated, he's tense, he's pacing around the ward, his mood, how is his mood, how is his affect. And in thought process, when you talk to patient, if you get the time to talk to patient, you might see the presence of paranoid ideation or delusion or persecution, and poor impulse and judgment might be seen in the patient. These are the scales. Yes, there were certain scales which are there, which you just remember the name. For psychiatry people, HCR 20 is historical, clinical, and risk management scale. You rate the patient based on this criteria, and higher the scale, higher is the chance that patient has tendencies of getting violent or is actually may be violent in future as well. Then again, this is Brosset violence checklist. In this, according to the time and day, you can write down and mark it कि patient has been confused, irritable, verbally aggressive or not. And one more thing to be noted is इसमें you also have whatever the what we call what action you have taken to calm down the patient, whether any action was required, whether verbal de-escalation has helped, or whether you have to give him some medication or something like that. Okay, very important ki how do you manage, especially in emergency situation. Ensure the safety first of all. Staff की अपनी और patient तीनों की safety आपको ensure करनी है. Try to de-escalate the situation and the patient and address the underlying psychiatric or medical cause. First of all, immediate safety and environmental control. Risk assessment, as we have seen, we will see by seeing the behavior of the patient or certain checklist, you can find out whether how much of the risk patient is having to act violently. Next is environmental modification. First of all, you should have support staff with yourself. 2 to 4 people should be there who should be trained enough to ensure your safety and patient safety as well. Safe physical environment. Ideally, the setting should be quiet with minimum stimulation. A designated calming room or seclusion area with soft furnishing and no sharp edges may be necessary. Remove potential weapon if at all, maybe a knife or a scissor that you can see in your emergency ward. Maybe patient might use a pen to harm you. So if possible, remove all these things from the likelihood, even the furniture or the sharp objects. Starting with verbal de-escalation. This is the first mode and the primary intervention to calm a patient. So you will approach the patient very calmly, use a soft, non-threatening language and maintain eye contact with the patient. Avoid standing just over the head of the patient. Okay, sudden movement भी avoid करना है. In case you suspecting patient is psychotic, avoid gesturing. जो आप हाथ हिला के बात करते हो वो भी avoid करना है. Be empathetic and you can use that sentences like, I can see you are very upset right now. Let's talk about what is bothering you. Again, another thing is offering choices. You might want to make feel the patient that he is in charge. Like, would you like to sit down? Is it okay if I take your vitals? Would you mind telling me? Are you comfortable over here or shall we move over there? So that the patient is thinking that, हाँ कि मैं in charge हूँ. I am having other choices as well. De-escalation technique, active listening. Why the patient is aggressive? Sometimes just listening can diffuse the anger. Next is distraction and diversion. Suggest an activity that can shift the patient's focus of distress, like offering a glass of water, suggesting a walk. Many times you might have seen कि लोगों को stress balls देते हैं ना punch करने के लिए, just so that his anxiety is being weaned down. Limit setting is something you should know. You should not be punitive or aggressive in your speech when you say that. For example, you can tell patient it is okay to be angry, but it is not okay to harm anyone. So let us find out, work on finding a solution together where we can help you out finding why you are angry, and we should not, any other person should also not be harmed. Next is your pharmacological or chemical restraint. So chemical restraint के लिए please remember it is not used to treat the illness but for intentionally inhibiting a particular behavior or movement which is causing the havoc currently. So both oral and IV or मतलब parenteral IV or IM medications can be given. Benzodiazepine, especially lorazepam, which you might have seen in emergency as well, and diazepam can also be given. Both IV IM doses can be given. Lorazepam 1 to 2 milligram is a good tranquilizer. So is the diazepam. Antipsychotics में haloperidol and olanzapine. Haloperidol, I think you are, which is most commonly is given in emergency setting. Olanzapine injectable, and there are other first or second generation antipsychotics which I think it is currently not available in hospital pharmacy, but are can also be used. Combination therapy of haloperidol, promethazine, and lorazepam is a very rapidly acting tranquilizer. It can also be repeated if the patient is not sedated. Please remember, promethazine should not be given IV. This is something which has happened in emergency setting quite often, but remember that, okay? Give them IM. Monitor for side effects, watch for sedation and respiratory depression, because you are giving benzodiazepine and other antipsychotic which might calm down the patient but have the chances for causing respiratory depression. So ABC of the patient should be taken into consideration. Then dystonic reaction, first generation antipsychotics like haloperidol can cause acute dystonia. So promethazine is something which can use to taper down the current situation. So this is how the patient should be restrained. It could be 2-point or it could be 4-point. In 4-point restraint, one arm is upward, one arm is downward, and two legs are tight. And in 2-point restraint, one arm and one leg will be tight. When do you restrain patient? If he is causing imminent threat, he might be cause harm to self or might be harmful for others. And if any form of de-escalation, whether it is verbal or chemical restraint, have failed. Okay, procedure. Restraint should be applied by a trained team under the direction of a lead physician. Each member should have a designated role कि एक आदमी हाथ बांध रहा है, एक पैर बांध रहा है, दो आदमी पैरों को बांधने में लगे हुए हैं, तो ये सब चीजें आपको you should be pre-decided. Restraint can be physical or mechanical depending on the facility, and it can be 2 or 4-point. Remember, restraint जब use करते हो तो it should not be very tight. You have to keep on check on vitals of the patient. अगर आप फिजिकल रेस्ट्रेंट यूज कर रहे हो तो मेक पॉसिबल कि उसके बीच में कॉटन लगा दो, जिससे कि वो ज्यादा प्रेशर ना पेशेंट के हाथ पैर में करे. Again, it should be used for the shortest possible duration. Once applied, monitor vital, consciousness, and circulation to prevent complication like positional asphyxia and circulatory issues. In medical evaluation, once the immediate threat is resolved, identification of the cause should be taken into consideration. Identifying cause, conduct a thorough medical workup to rule out any organic cause such as of aggression, such as delirium, TBI, seizure, electrolyte imbalance, any intoxication, or any psychiatric cause. Long-term management focuses on preventing future episodes of violence by addressing the underlying psychiatric or medical condition. Pharmacotherapy may be antipsychotic, mood stabilizer, anti-epileptic, antidepressant, and psychotherapy and behavioral intervention should be taken. Another thing is legal and ethical consideration while managing the violent patient. Okay. Involuntary admission, Mental Health Care Act 2070 says if a patient is possessing harm to self or himself, he or she can be admitted under the involuntary admission. That means the consent from the nominated representative of the patient should be taken. Our patient who lack the capacity to make informed decision can be taken under involuntary admission. Use of physical and chemical restraint should be applied whenever it is necessary. It should not be like halka sa patient ko gussa aa raha hai, aapne baat diya, no. Informed consent from the nominated representative in case when you are restraining the patient, and this consent should be retaken after 24 hours. अगर आपने अभी बांधा तो ऐसा नहीं कि कल भी आपका वो कंसेंट चलेगा, आपको कल नया कंसेंट लेना है, ठीक है. Please आप consent तो ले लेते हो, you don't document when you are restraining the patient. Write down the date, time when you are restraining the patient. When you are opening the restraint वो भी करना है, हर 20 मिनट में vitals भी लिखने हैं, और पेशेंट को कैसा रिएक्ट किया, ये सब कुछ आपको कंसेंट का डॉक्यूमेंटेशन में आना चाहिए, रेस्ट्रेंट के डॉक्यूमेंटेशन में आना चाहिए, including the reason for its use, the type of restraint applied, duration, and the patient's response. Reason for its use की failed verbal de-escalation भी लिखना है आपको, chemical restraint not possible और failed ये भी लिखना है आपको. While the patient is restrained, the physical and mental condition should be continuously monitored. Again, the same thing, and please maintain patient's dignity and during the restraint and sedation process. Patients who have made homicidal threats or committed violence act may undergo psychiatric evaluation to determine their mental competency to stand the trial. clinician must carefully weigh the ethical responsibility of maintaining patients' confidentiality against the duty to protect potential victims. I think in United States there is a law if a patient is presenting to you who have said कि homicidal threat दिखाए हैं, तो you have to report it to the law enforcement agencies. In India, although there is no law, but big moral act के उसमें आप कर सकते हो inform अगर आप चाहो तो. Conclusion again the same thing. Violence is not uncommon. Complex interaction of biological, psychological, and social environment is there. Early identification of risk factor and past history of violence is crucial for preventing the escalation. Management is psychiatric emergency setting requires comprehensive multidisciplinary approach, and you should prioritize safety and effective treatment, legal and ethical responsibility. These are your references. Thank you.